I would like to thank SAGES for the opportunity to present in this session the update on imaging of technology of neural structures in surgery. These are my disclosures. The nerve injury is really a very important topic during the surgical procedures because every time we dissect or we want to resect the tumor, we may injure the nerves, compressing them, or may provoke the loss of the sheaths of the nerves, or even we can cut the nerves if we cannot see them. And this provokes to the patient a loss of quality of life due to debilitation, paresis or paralysis, sensory loss and paresthesia, loss of limb function, or even organ dysfunction in some cases, and chronic pain in some of the procedures. And this is one of the main causes of litigations that we may experience when we injure a nerve. The frequency of these nerve injuries depends on the different surgical procedures. During parotidiectomies, we may find up to 33% of transfacial nerve weakness and up to 2% of permanent weaknesses. During prostatectomies, up to 20% of the cases, the patients may experience urinary incontinence or impotence. If we look at other different procedures, the numbers are even higher in some cases. For example, in rectal cancer resection of 25%, or hip replacement is 7.6% of nerve injuries. And this really increased the cost in the procedures. What do we have so far in order to decrease this kind of injuries? Neuro monitoring is only for motor nerves, and this is not always available. And even though we have that, we didn't have the chance to decrease the nerve injuries. In the last years, a cutting-edge technology was developed, and this is the real-time fluorescent guided surgery, and has been applied for different other procedures or to visualize different structures. For example, it has been used for laparoscopic cholecystectomy, and it has been demonstrated in prospective trials the increase of visualization of the extrahepatic biliary ducts when compared to white light. And also, it has demonstrated to decrease the anastomotic leak rates during colorectal resections and improve the patient outcomes in plastic surgery when the perfusion of the flaps is evaluated under fluorescent view. The adoption of this technology has also increased in the last years, and this can be clearly seen in the amount of publications that are available nowadays. This kind of technology also is studying the way we can see the different nerves, and what this has been described in the literature are two different ways. The first one is by administering a specific dye or probe intravenously. The dyes travels through the vessels and bind a specific nerve, and then when we use a specific imaging device, then we can capture the images of the fluorescence of the different dyes that are binding to the nerves. The other possibility is to use a specific equipment that are not going to use any kind of dye, but it can reflect or can capture the image of the fluorescence after the nerves are exposed to a specific wavelength. And with the use of different filters, a fluorescent image can be captured. The use of the different probes was summarized in a paper published in Annals of Surgery in 2019. The description of the two different agents was reported in the paper. Non-specific agents like indocyanine in green that can make the different nerves glow, but also make other structures glow, so it's not specific for nerves, and others that were designed to touch specific regions of the nerves, like vasa vasorum, endoneurium, axonal synapse, nasal substance, myelin, or directly the axon. The main limitation of the different probes is that they are being used in ex vivo models or in animal models, and it's going to take really a lot of period of time until they are approved by the FDA. When talking about the indocyanine in green that is being used for other surgical procedures, the dose that has been described is 0.25 milligram kilogram body weight. It's intravenously administered. At the moment we want to see a nerve, we administrate the dye, and we can differentiate nerves from different other structures, but also we need to consider that other structures may glow, so we have false positive. And on the right of the image, you're going to see how it looks like. The wavelengths that make the indocyanine glow is 780 nanometers, is near infrared light. Specific dyes has been extensively described in the literature, like the ones that I am showing you here, the fluorescent tracer that tags the myelin protein 0. It can bind the different nerves, and this was clearly visualized in a mice model when the sciatic nerve was exposed to a specific wavelengths. This is an experimental model, and the dye ALM 488, same situation. It was tested in an animal model, and the sciatic nerve can glow when the dye or the probe tags the specific nerve. We tried to develop a technology with different researchers in order not to use a dye, and this was published this year in Surgical Endoscopy. We combined specific wavelengths and filters, and we exposed human nerves to this combination of emission lights and filters, and we could evaluate that the nerves glow under near ultraviolet exposure and specific filters. The second step that we put together was the development of an animal model. We used the same equipment that was designed, the axon imaging equipment. We used different light intensities, 20%, 35%, 50%, and 100% of intensity of the LED. And we could differentiate the nerves from the different structures by using fluorescence. And there was a different fluorescent ratio between the nerves and the other structures that is shown in the curve that is below on the right of the image. Then we put together a human experience with the axon imaging technology. We evaluated 45 patients during thyroidectomy, neck dissection, parotid gland resections, peripheral nerve surgery, and spine surgery. In those cases, all the nerves glow, and autofluorescence of the nerve could be seen. In this case, a regular laryngeal nerve that you can see there on the right side of the image, the white light on the left side, the fluorescent view of the regular laryngeal nerve. After a dissection, neck dissection, because metastasis of papillary thyroid carcinoma, we could see under the fluorescent view the phrenic nerve. Same situation happened during parotidectomies, where the branches of the nerve, the superior and the inferior branches of the nerve, could be clearly visualized, and the sensitivity of the equipment was really very high because small branches could be seen glowing. Here you have another image of another case. This is during a parotidectomy. The main branch of the facial nerve and the superior and the inferior branch. And here you're going to find a real-time dissection, 73-year-old patient with a parotid gland tumor. And then we dissected the nerve under the fluorescent view of the nerve, and here you can see how the nerves are glowing. All the branches, the small branches that are superior, inferior, and also the branches that are in the middle. At the end, we tested the functionality of the nerve by using the neuromonitoring, and we combined both technologies at the same time. Patients with peripheral tumors were evaluated with this technology. Here you can see a schwannoma that was not glowing, and the nerve that was in the middle of the tumor was glowing, and we guided the dissection with the tumor. And also in the spine surgery, we could see how the roots of the nerves that were coming out of the spine glowed when using the technology. So to conclude, the fluorescent real-time visualization of the nerve is feasible. In a specific and specific dyes are being developed in order to make the nerves glow. Long-term prospective randomized trials will be needed to determine risk and benefits of the use of new dyes, and autofluorescence of the nerves seems to be a safe option to increase the nerve visualization during surgical procedures. Thank you very much.